Hello, good morning, everyone. Can you hear me?
Yes, Jane. Loud and clear.
Hello, good morning, everyone. I am Dr. Jane here, a general surgeon currently working in Queen Elizabeth Hospital, KK. So today I will be the moderator for today's session. Today's session is another part of our Peri-operative medicine webinar series. In particular, today's topic is in relation to the peri-operative kidney and bladder strategies. So we are going to focus on two particular critical yet often overlooked aspects of peri-operative care, which is maintaining the renal function and ensuring optimal bladder management for our surgical patients. So we'll not only explore the practical evidence-based approaches to minimize perioperative kidney injury, other than optimizing bladder care, as well as balancing the benefits and risks of particularly in bladder catheterization. So we hope that together these strategies will aim to improve our patient outcome and reduce any perioperative complications. So without further ado, I will introduce two of our speakers today. First is Dr. Mr. Muhammad Fairuz. He's a urologist surgeon, clinical lecturer from University Putra, Malaysia. He will be talking regarding bladder catheterization, risks and benefits. And our second speaker for today will be Dr. Jason Kong. He is our nephrologist stationed in Queen Elizabeth Hospital. He will be also speaking on the risk of acute kidney injury and its management surgeries. So before we start, just a few housekeeping rules. This is also can be seen in our chat box. So if it's possible, please mute, turn off your video. And if you have any questions relating on our topics today, you can use our Slido link also found in our chat box and enter your question there. At the end of the session, we will have a Q&A session. Otherwise, this peri-operative webinar will be recorded and you can always refer back to our YouTube link later on. Also, don't forget to send us a feedback form at the end of this session. Thank you very much. So without further ado, we proceed with Mr. Fairuz's first slide. I will stop share for now.
Can my slides be seen, Jane?
Yes, can. Very nice.
Okay. Okay. Morning, everyone. Assalamualaikum and a very good morning to the audience. I'm Fairuz. I'm a urological surgeon from UPM and also a senior lecturer there. So I've been given this task to talk about bladder catheterization, risk and benefits. To the simple doctor, it would seem that catheterization is a very simple subject, a simple matter, but in actuality, actually it carries a lot of morbidity if not done properly, and it can cause a lot of problems as well. So why does this topic matter? Because bladder catheterization is common, it's very common, I would say, but it's not risk-free at all. And it is associated with morbidity, infection, and trauma if you don't do it properly. Perioperative safety depends on proper indication of inserting a catheter and the care that comes afterwards. So wrongful practice even has been known to be handed down for generations on this simple task of inserting and taking care of the urinary catheter. Right. So what is it that we would like to achieve in today's simple session is just to understand simply the indications for catheterization. We must recognize its risk and complications and apply preventive strategies to reduce harm. But the most important thing for everyone, regardless of how senior you are, is to always bear in mind that no one doctor is beneath the task of inserting a urinary catheter. It is a simple procedure, yes, it is a common procedure, yes, but within it can come a lot of problem. Okay, this is a true story. where I was involved in the legal aspect of this case. In one of the public hospitals in Klang Valley, in a government hospital, a surgeon wants to do a surgery in the area above the neck. I'm not gonna disclose more than that. And he asked a junior nurse to insert a catheter. So again, looks like a simple task. Surgery was successful, but at the end of the surgery, then only he realized that the bladder was distended and there was no urine output in the catheter. There was blood at the meatus. So we were called from some distance just to reassess because the patient underwent a surgery above the neck and now there's injury in the urethra. How can we explain this to the patient? So it was a difficult case and there were a lot of legal aspects to this, but in the end, everything seemed to be fine. And now the patient is still under our annual follow-up just to make sure that he will not develop a urethral stricture. And this is again another true story in one Malaysian government hospitals where this is during the COVID era where patients are known to be catheterized and be nursed in a prone position for some time. And this is what happens. This is what we call an acquired hypospadias. And to repair this is a very daunting task. The surgery will take at least 3 hours. And the success of the surgery can sometimes be difficult to achieve. Okay, this demonstrates how a simple task of urinary catheter insertion can give rise to a lot of long-lasting, difficult complications, difficult for us to manage. Not just urologists, general surgeons, nursing staffs, and doctors involved in the treatment care of the patient. So, first of all, we must make sure that the indications are correct. We cannot just simply put in a catheter without knowing why. Every time we are asked, even though we are a junior doctor, even though it's our first day on the job, whenever somebody asks us, hey, would you mind inserting a catheter into this patient? You must ask yourself on behalf of our patient, what is the indication for me to insert a catheter for this patient? So these are the common ones. This is a non-exhaustive list. There might be others, I'm sure. Acute urinary retention or chronic urinary retention if symptomatic or with renal compromise. If you want to bypass a bladder obstruction due to prostate, due to stricture, we want to nurse critically ill patients. A number of perioperative and post-surgery patients will usually require catheters. Facilitate bladder irrigation. Sometimes we do that to instill medications, but this would be mainly in urological wards, such as intravesical mitomycin, intravesical BCG for bladder cancer, and urinary diversion sometimes to promote healing of wounds. Let's say the patient has a significant perineal wounds or sacral sore, we don't want to be contaminated by urine, or immobilize patients who are severe enough that would warrant them to be completely rested in bed, such as fractured pelvis. And lastly, sometimes we do consider to promote comfort care during end-of-life care for palliative patients. But what are the benefits? I'm pretty sure most, if not all, the audience are aware why we catheterize, mainly for diagnostic. We want to assess renal function. Therapeutic, we want to relieve obstruction. We want to monitor the renal output. And sometimes protective because we want to support surgical healing. And urinary diversion, surgical healing such as in anastomosis of the urethra and bladder. And sometimes, as I mentioned before, medium to deliver medications. But then come the practical aspect of catheterization, the types of catheters. These are the main types of the catheters that we use in day-to-day practice. One is not really common in Malaysia, where we use intermittent self-catheterization. These are in patients who are usually incapable of voiding naturally on their own. So we will instruct them, we will advise them, we will teach them how to insert self-catheters. And to a clean manner and intermittently. This has the lowest infection risk, and if a patient is required to be on long duration of catheters, then we would usually advise for CISC. In indwelling catheter, which is the Foley, the one which has a balloon in it, that is common as a perioperative option or for the indications that I mentioned. And again, a suprapubic catheter where we have a patient with surgically created tract in the suprapubic region. And of course, we have the three-way catheter for continuous bladder irrigation. This one is mainly for urological use, whereby, or sometimes when patient presents with hematuria, we want to irrigate the bladder while waiting for our urological colleagues to come and reassess, or our general surgical colleagues to come and reassess. This would be a three-way catheter where there is an inflow of saline and outflow of urine afterwards. Okay, these are the catheter sizes. I'm pretty sure the most common that would be used would be orange and green, which respectively would be 14 and 16 French. The size in French is actually can be converted to millimeter by dividing it into 3. As you can see here, 6 millimeter, 6 French equates to 2 millimeters, and this is the diameter of the catheter. Okay. And size considerations. This, although seem a bit petty and sometimes why do I even have to ask? Why do I even have to explain about size considerations? But often overlooked, but carries a significant impact on catheterization. There are issues with large size catheters. As doctors, sometimes we would say the bigger the catheter, the better it is in terms of drainage. Yes, that's true in terms of drainage, but we must understand that the urethra is a living tissue, and the larger the catheter, the higher the chance for urethral trauma, because there will be more erosion on the bladder neck and urethral mucosa. And this, in the long run, creates a state of chronic inflammation and also stricture formation. And don't forget that the urethra has periurethral glands, which secretes secretions. And by stretching them, by blocking them with the large size catheters, you are actually causing more irritation, infection, and blockage of these glands. So we do use large size catheters 20 to 24 French, but this is mainly for drainage of blood clots, because we know that blood clots are bigger in size and would need a bigger channel, right? But most common in use in day-to-day practice would be 14 to 16 French. 14 would be the one with the green colored head, and the 16 French would be the one with the orange colored head. And adolescents, usually around 14 French, which is irregardless of gender, would be around the green sized, the green colored catheter. And for pediatric, I must stress this here now, if you can't take home anything, at least please remember, for pediatric patients, it is preferable not to catheterize the patient if possible. Even if you catheterize, try not to inflate the balloon of the catheters. Meaning, I would rather, sometimes patient comes with acute urinary retention due to phimosis, pathological or physiological phimosis. We would usually just insert a feeding tube and tape the tube to the foreskin. It's better, even though the tube may dislodge over time, but it's always better not to inflate the balloon, because the risk of trauma is higher in children who actively moves. And if trauma happens in children, urethral trauma, managing the urethral stricture, which comes later, is very difficult in children, because they have to go to school, they have to see their friends, the psychological impact, they will be growing up. So the urethra and the penis size changes as they grow up. So it's very difficult to manage the urethral strictures, right? And the duration and stewardship, we must understand that catheter-associated UTI risk increases every day that the catheter stays in situ. So you must minimize. As long as you feel that you don't need it anymore, please take off the catheter. It's a major risk factor for developing UTI in patients, having a catheter inside. And you must implement daily review and remove as early as possible. And to prevent trauma, use a bladder scan to make sure that the bladder is inflated in the bladder. This is especially when you think that it's a difficult insertion, you're not really sure if the balloon is in the bladder or not. You can use a bladder scan. And this is most important. Some people would like to be heroics. They don't think that the catheter needs to be inserted up to the hilt, the junction. You must practice inserting the catheter even in females up to the hilt before inflating the balloon, but especially in males. And because it's just a simple step, but not doing it causes a lot of trauma and unnecessary referrals, unnecessary morbidity to the patients, and subsequent management. And again, I must stress out here, avoid unnecessary catheterization in children. What are the risks? Why am I being so pedantic, being so extra cautious on catheter? Because there are risks and complications. Having a catheter for a long time increases the infective rate, the patient to get catheter-associated UTI, mechanical problems such as trauma, false passages, strictures later on. And even if none of those happen, you must understand that when the patient is catheterized, then the urine will continuously flow from the bladder, and the bladder will become atonic for a long period of time. And you must understand that the bladder is lined by muscles. This same muscles contracts the bladder whenever we want to pass urine. So when you put it in an atonic phase for a long time, the muscle becomes weakened, and for a long period of time, sometimes you can have bladder dysfunction and delayed voiding, sometimes up to the extent of detrusor underactivity. And short acute problems patients may have bladder spasms, urethral irritations, and rare, not to say rare, but I've seen it happen more than once, when encrustation happens, where there will be stone formation, especially if the catheter is left without being changed appropriately. And sometimes you have periurethral leakages, which may be uncomfortable for the patients. So again, I must stress on catheter-associated UTI. 45 to up to 56% of UTIs are associated with having a catheter. This is based on a very strong study. And to prevent this, of course, I think the audience here are mainly doctors who understands the value of aseptic insertion, close drainage, and daily review of catheters when we do rounds. At least just have a look. It's just 5 seconds, and you will just have to have a look at the catheter and see whether if it's and the content of the urine, whether if it's turbid or whether if it's pus, and avoid unnecessary antibiotics unless indicated, because we want to prevent resistance. And as a urologist who has great interest in functional urology and reconstruction, I must stress out urethral trauma and strictures, because urethral strictures are in general difficult to treat. That's why not many urologists prefer to treat them or embark on the training that is required to correct this urethral stricture. So it mainly occurs with difficult insertions or repeated trauma. If you cannot get the catheter in, do not force it to go inside. Call us early. There should be no urology medical officers or specialists who would reject your call, even though it sounds like a simple task of inserting a catheter. And how do we do it differently? I'll just share with you what are our tricks of the trade. It's not that difficult, to be honest. The first one especially, generous lubrication. General lubrication, and ensure it's of the correct size, right? So the gel, if you can see in the last point, the gel is not a dipping sauce. The best way to introduce the gel into the urethra is to inject it into the urethra and give some at the urethral meatus. If you do this properly, actually solves, I would say, 70 to 80% of the time, prevents a urethral trauma. And how we do things differently, sometimes we can show you how we put our fingers in the right places in both males and females, how we lift the prostate up, how we, especially in females, how we can, through the vagina, we can actually feel for the urethra and guide our catheter insertion. We sometimes use wire guidance, and this one can be taught. If you hang out with urologists long enough, you can do cystoscopy guidance. And I'm pretty sure general surgical medical officers, urology medical officers are familiar with cystoscopy. We just need to teach you the extra step of how to insert a wire through the cystoscopy and then later guide a catheter through it. And very rarely, this one, sometimes I do in theater, would be fluoroscopy guidance. Okay. I'm pretty sure we are aware regarding Foley and Foley latex catheter and silicone catheters, but you must understand the main differences is not just about how it looks like. The main thing is that the silicone catheters are harder, they are less pliable, and the latex catheters are softer, so they are less traumatic, but the Foley catheters are less allergenic. They can stay longer, up to a month. And sometimes in difficult situations where patient has difficulty to come, we can negotiate up to 2 months, but this is off record. And the infection risk is significantly lower in silicone catheters, but when you put it at a longer duration, then sometimes at the end of its duration, the risk of UTI becomes higher. And of course, cost is much more for the silicone catheters compared to the latex one. Okay, this is something that even when I was a medical officer, I was not introduced to this early, but I wish I had. If you manage patients with urethral obstruction, either due to BPH or due to strictures, and they are on long-standing catheters, it's worthwhile to invest on this catheter valve compared to leave it hanging on a bag. It's relatively cheap. You can change it every time, in every 30 days, it needs to be changed. And in the meantime, it needs to be cleaned regularly. So what it does is that it acts like just like a valve, so that whenever the patient feels that the bladder is full, he can empty the catheter in the toilet, or sometimes, I mean, less preferably in a sink, just like a tap. How is this more advantageous is that it keeps the bladder distended when it is full of urine and contracts when it wants to expel urine. So it keeps the bladder, the muscle tone of the bladder, preserved compared to having it continuously draining on a bag. Okay, and patients will almost always feel much better because they don't have to carry a long-winded bag, a heavy bag, which sometimes can leak and sometimes can cause embarrassment in public. This one can be hidden inside the underwear for males and for females. So we're reaching, I think, almost the end of my presentation. What is our role as doctors here in terms of catheter? Again, every time you are asked to insert a catheter, understand and ask yourself, why am I inserting this catheter? Feel free to ask whoever who asked you to insert the catheter, what is the indication? Do I really need to insert a catheter? And if you do need to insert the catheter, insert it properly. And you must train your staff, your nurses, to take care of the catheter afterwards, after you've inserted, and advise the patient on how to take care, not to tug, not to pull the catheter. And if patients really don't want to have a catheter in, you should not offer the catheter to them, because it's riskier to put in a catheter in a patient who is at high risk to pull out an intact catheter and cause significant urethral trauma. So you must lead a multidisciplinary stewardship in your own hospital, in your own team, in your own unit, to take care of catheter from insertion until its removal. So the key takeaways for my presentation is that catheterization should always be justified, should always be inserted at the right size with the right technique. Early removal prevents catheter-associated UTI and trauma, unnecessary trauma, and urologists must lead safe perioperative catheter care. Not only urologists, but surgeons, doctors, wherever you are, you must lead in terms of catheter care. These are my references. It's well established in the European guidelines, CDC and NICE guidelines, and a few studies. Okay, if you insert it, you own it. Thank you.
Okay, thank you, Mr. Fairoz. Very nice lecture. If anyone has any questions, I think you can send it. You can open our Slido app there and send your questions in. I'm sure many people have a different opinion on management on the bladder care, and you can find out the answer through Mr. Fairoz here later. So it's about almost 10:30. We will have an interim break here. I would like to share and promote our society's first symposium, which will be held next year between 28 to 29 of March in Connection, Nexus Bangsa South. Very nice place. It has everything there. Makan place, hotel place. Don't really have to move anywhere, especially from people like us from Sabah or Sarawak. So remember to save the date. It will be a very interesting discussion during that time. And as well as our social media, you can see here, you can follow our page just to see what is our latest updates in our society. So in about 3 minutes, we will continue with Dr. Jason's lecture regarding management of AKI in the perioperative period. You can grab a coffee or perhaps use the loo at this moment. We will reconvene back in about 3 minutes. Again, if anyone has any question, you can send it through the Slido app Zoom. Okay. Hi everyone back. So without further ado, we will proceed with our second speaker of the today, Dr. Jason. I will let him reintroduce himself with his topic. So I will stop share for now.
Hi, good morning, everyone. Thanks, Ms. Jane, for the kind introduction. Yeah, I'm Jason here, nephrologist in Hospital Queen Elizabeth, based in Sabah, Kinabalu. And thank you, Mr. Fairouz, for the very insightful talk. I didn't actually notice that urinary catheterization can be so complicated. But thinking back as a junior doctor, when I was in my first posting itself, I remember it's very stressful to do a urinary catheterization because my first urinary catheterization is in the operating theater just before the patient was supposed to go for emergency Caesar. So all eyes will be on you, you know, the anesthetists, the surgeons, the staff, everyone. So if you get one step wrong, that's it. You get extended. So nowadays, I'll be thinking more to how do I remove the catheter, you know, when patient is on very prolonged period of catheterization, when you remove and they develop acute urinary retention. All these are is more to my concern nowadays rather than insertion. So yeah, I really learned a lot from the first talk. So without further ado, everyone can see my slides here.
Yep.
Yeah. See your slides, yeah.
Yeah. So I'll be talking about perioperative AKI risk and management. So why is it so important? As we can see here, globally, the incidence of AKI throughout the world actually varies very widely from North Africa of 0.7% to our own Southeast Asia, about 31%. Why is this so? Because in North Africa, you know, the accessible to healthcare is very limited. They might they can all these patients they can access to healthcare, but the resource setting might be limited. They cannot send renal function tests, so it will be under-recognized, and sometimes they will be delayed in recognizing the patient might develop AKI. So every countries have their own epidemiology and data, and it varies across the nation, about 20 to 30%. So closer to home, actually, we have a study by our intensive care colleague here based on 4 tertiary hospitals way back in 2010 to 2014, looking at the incidence of AKI in ICU. And they found that the incidence of AKI in critically ill patients can be as high as 24% just within 24 hours of admission. And 64% of this patient that has AKI has concurrent sepsis as well. They are more prone to infection, or vice versa. The sepsis itself is the one that causes the AKI. We don't know. It's a bidirectional relationship. And the mortality is very high in those patients who develops AKI, 48%, those who have AKI versus 20% as opposed to those who don't have AKI. And not to be undone by the intensive care colleague, the Nephrology Society actually did a prospective study, just a 1-month study. This is way back in 2017, okay, where they screened about 21,000 patients in that 1-month period. If I'm not mistaken, it's about, I think there's 5 hospital that is involved in this, sorry, a lot of hospital we can see, not just 5 center. So they screened about 21,000 patients, and then they found that regardless whether the patient come in for elective admission or emergency admission, they found that about 7% of patients has AKI. And to some of us, we think 7% is nothing. It's very, like, it's something very not very high in incidence. But if you do some number crunching, 7% out of 21,000 is about 1,500 patients, and in just 1-month period. And out of all this 7% of those patients with AKI, 27% of them has infection, and about 8% needed dialysis support, and 8% again out of 1,005, 8% translate about 120. And to some of us, we think 120 is not a very high number. But bear in mind, the study is conducted only for 1 month, looking at 1-month period. So if you have patient in that one month period, you needed dialysis, 120 patient, that is a burden itself to the healthcare setting and resources. And out of This 1,500 patient, 8% died inpatient, okay? And about 8% did not develop any form or any signs of a renal recovery needing a long-term kidney replacement therapy. And then back to our context here, there's a study conducted looking at the post-operative acute kidney injury at this AKI. This is an international study in 30 countries. It's a very big study, mainly looking at just post-operative AKI, whatever surgery, and patient that develop AKI within that 72 hours, that's their primary outcome. And they found that 1 in 5 patients develop AKI, about 18.4%. And out of this 18%, 33% of them have persistent AKI, and 8.7% needed kidney replacement therapy. And this translates to longer hospital stay and also higher mortality rate among all these patients that develop AKI. And as we can see, AKI itself plays a huge burden in our inpatient care. But before we move on, we need to know what is the definition of AKI. To make it simple, AKI just look at two parameters. For many, many years, it never changed. Okay, there are many classifications in the past, like rifle and Akin classification. Don't really need to dwell into that. But since 2012, KDIGO has come up with a definition of AKI looking at the serum creatinine as well as the urine output. So only two parameters. It's very simple, but there's a quote in nephrology. Nephrology practice is very simple, but it's not easy. Okay, we don't just look at parameters to decide what to do. So KDIGO classification here, the definition, basically there's 3 stages of AKI, looking at the serum creatinine, which is if there's an increase in your serum creatinine 1.5 above the baseline. If you don't have any baseline, it's a bit difficult for you to know whether this is AKI or CKD. So there's some definition that we can look into that just to differentiate between these two. So serum creatinine or serum creatinine increase more than 0.3 mg per deciliter, that translates to about 26 micromillimole, okay, which is our unit that we use in a hospital. Okay, or urine output less than 0.5 mils per kg per hour for the past 6 to 12 hours. And then of course, stage 2 is in between. I don't want to elaborate too much, but stage 3 is most of the time patient needed dialysis support. Okay, when we have an anuric patient with worsening creatinine level, we know the trajectory is not that good. Yeah, most of this patient will need some form of kidney replacement therapy. So to confuse you further, there's few definition, but I try to make it simple. AKI, we know we are looking at the creatinine and the urine output, and then we know what is CKD, right? Everyone should know what is CKD. I remember my senior consultant came for grand note rounds. He asked all the junior doctors, so what is the definition of CKD? Some of them say creatinine. What's the creatinine level? Look back at the 3 months creatinine, okay. So GFR is one of the components to look at the definition of CKD, anything GFR less than 60 mils per minute for the past 3 months. Not just the GFR, but we also look at the structure of the kidney or any abnormalities in the tubules or urinary abnormalities. So even patient living with a single kidney, patient with a kidney stone, patient with a cystic kidney disease, all these are considered CKD. Even patient has any abnormalities in their urinary sediments or microscopy, it's considered CKD. Okay, whatever is in between is called acute kidney disease, okay, AKD. Don't really need to know all this, but it's just to help us to define. But most of the time when we don't have a baseline creatinine, we don't have enough information whether this patient is AKI or CKD. We tend to treat patient as AKI, but of course we have to assess patient and get more information. Okay, I won't dwell into this busy slide here, so I'll just move on. So is creatinine good enough? If we compare the heart and the kidney, many years ago, we have a few biomarkers to diagnose acute coronary syndrome or any heart condition. Looking at the history back in 1950s to the 80s, there's so many biomarkers that used to diagnose any heart condition, like your AST, LDH, CK, CKMB. And then in the late 80s to 90s, we use myoglobin, cardiac trop-I or trop-T, and BNP, which we still using nowadays. And then in the present, we use higher sensitivity cardiac troponin. And then there are all these novel biomarkers. Actually, there are more. I just run out of space to include everything. So if you look at the kidney, we don't have a lot. We are still stuck at creatinine actually. So early biomarkers, of course, in the past, we tend to look at the urea, the blood urea nitrogen. We don't really look into that anymore. The lab don't routinely measure this anymore. And then nowadays, traditional biomarkers, we are still stuck at creatinine and urine output for many years. Of course, there are other new biomarkers like your KIM1, NGAL, cystatin C. Bear in mind, all these biomarkers it's not something new. It has been there for more than 10 years. It's just that in clinical practice, it's not easy to utilize these biomarkers. If I give you a KIM1 value, I probably won't be able to interpret it as good as looking at the creatinine serial trend. Okay, even cystatin C. And then why are we still stuck with creatinine? Because it's readily available and it's cost effective. So hands down, the heart here wins the kidney. Okay, and then we talk about creatinine as a biomarker. Is it good enough? So we have to bear in mind creatinine is not an absolute numbers that you look at single parameters and make clinical decision on. So we tend to look at the serial readings. So the serial creatinine concentration usually lags behind acute changes in kidney function. In AKI, most of the pathophysiology that causes AKI, the damage is at the cellular level. Okay, perhaps there are more in the molecular level. Okay, like your AKI sepsis. In the past, we tend to think patient with sepsis develop AKI. It's all acute tubular necrosis, meaning if you do a kidney biopsy, you see the tubules, they are abnormal. But after a while, over the years, all this stigma has moved away from acute tubular injury because actually AKI is not just at the cellular level. Okay, so it's more to molecular level nowadays. We don't really know. There are a lot of postulation like your cytokine production causes AKI. But at the cellular level, if you do a kidney biopsy, you might not see anything at all. Okay, so and creatinine production is usually affected by a lot of factors, like different patient has different body habitus, sarcopenic patient, elderly population, and which we are handling more and more nowadays as our population is aging, and it can get diluted in fluid overload status, and it differs with age, gender, diet, nutritional status. And most of the time, creatinine can be delayed in 2 to 3 days time. Okay, if the patient develop AKI, you might not notice it after a few days, especially in ICU. In most ICU setting, you look at your renal function 2 times a day, depending on the need. Okay, so it might not reflect the true trajectory of the patient's condition. So moving on, what are the risk factors for AKI? There's so many risk factors, right? But in general, when we look at risk factors, there are patient's factor and external factors, environment factors. Moving on, we have modifiable factors and non-modifiable factors. All this we know can cause AKI. Patient's condition when they presented to the hospital, whether they're dehydrated, they have underlying kidney disease, they are on any medication that can predispose them to AKI, or they come in a very bad shape, or they are exposed to contrast related procedure like your CT scan. Okay. And non-modifiable factors the comorbidities itself, like diabetes, CKD, heart failure, liver failure, and age. Okay, environment factors, although we thought environment factors is not a cause of AKI, it's not a risk factor. What are you talking about? All this doesn't sound logical, but if we look into a case scenario later on, which I'm going to show you, all this actually plays a role in patient that can develop AKI. Okay, how about in our perioperative patients? There's so many factors. It's a very busy slide. We can go through this one by one, but we know, but what I want to highlight is the procedure-related factors here. There are many types of surgery that we do. Nowadays, surgery has evolved into a very complex there's a lot of complex need for every patient, more and more techniques, more and more procedures, and more precision-based procedures. And in many studies, the cardiac and vascular surgery tend to have higher risk of developing AKI. And of course, we have to ask ourselves whether the procedures is very complicated, needing a very long duration, and whether they need a mechanical circulatory device assistant, okay, in most settings, the cardiac surgery. So let's look into this gentleman. This is Mr. CF. He's an 85 years old man. He has multiple comorbidities, diabetes, ischemic heart disease, hypertension, hyperlipidemia. I'm sure most of you encountered this kind of patient before. Okay, and he is on a lot of medication as well, aspirin, amlodipine, basically a lot of antihypertensive, anti-diabetic agents, as well as some supplements. Okay, and he presented to the casualty, unable to ambulate for the past 1 week after a fall, and diagnosed to have right neck or femur fracture. But he is not able to come earlier as family members is not around to bring him to the hospital. And in the emergency department, he has on and off pain, which requires some painkillers, so he was given Celebrex. Okay, perhaps that time the creatinine is normal. And then he was admitted to the ward. And nowadays, our ED is so congested, sometimes they can get warded up only after a few hours or more than 1-2 days. And then in the ward, they develop shortness of breath and suspecting pulmonary embolism. And he was planned for CTPA. And the junior doctor actually repaired the creatinine level because the radio people asked for it and noted the creatinine is 330. So from this case scenario itself, we can see there's a lot of risk factor for this gentleman to develop AKI. One is their age itself and the multimorbidities and polypharmacy. On top of that, given Celebrex. To us, a single dose of Celebrex in a patient with a normal kidney function is actually okay, but bear in mind, in elderly population, their physiological reserve is less. Okay, they don't have a lot of physiological reserve, and also their hemodynamic response is not as normal as a healthy population. So one dose of NSAIDs or any COX-2 inhibitor can cause a lot of problem. Okay, and delayed presentation. We don't know what happened for the past 1 week. Is he eating well? He might come in very bad shape. He might come in very dehydrated state. And then now the patient needed the CTPA to rule out pulmonary embolism. So that will subject the patient to contrast exposure. So how do we approach? The management is multidisciplinary. There's no one team to manage this kind of patient. Okay, the orthopedics, we don't expect the ortho surgeons or any doctors to manage this complex patient. This patient has very complex need, multimorbidities. So most of the time, this patient will be referred to medical in the casualty itself. So what do we do? So there are a few things that we look into. Okay, so the management according to KDIGO, and this is a very old guideline since 2012. It has never changed since. 2012 is more than 10 years ago, and when we look at the recommendation, it's something very basic. Okay, but it's a lot of recommendation here. But what I wanna, how do we approach generally is to rule out reversible or mitigating worsening AKI. Okay, so find out the reversible causes. I think we all know what are the causes of a kidney injury: pre-renal, renal, post-renal. Okay, we are very good in detecting post-renal causes. Okay, just do one ultrasound, just take a few history, any acute urinary retention. But sometimes in patient, elderly population, they might not even complain to you. They have difficulty urinating, okay, until you really dig into their history. So this is very easy to rule out. So the first thing we can do is just do a bedside ultrasound or just palpate whether the bladder is palpable. And then of course we have to assess their volume status, so whether they have any acute bleeding that causes a pre-renal AKI. And of course, renal causes is a bit more difficult. Okay, so we have to look into their drug chart. What is the patient on previously and what is the patient on? Okay, for instance, for this patient, if you ask me, most of the time, my approach is not just to discontinue the nephrotoxic medication. If a good doctor, yes, they can do that, okay? But a better doctor is more holistic in their approach. So you ask the patient, which medication are you taking? You'll be surprised, even in clinic, most of these elderly patients, some of the patient, they will tell you, oh, this medication I only take once a week, or maybe I don't take at all. Okay, so all this medication, you have to reevaluate whether they are really taking it, whether it's really useful in their condition, and especially in this patient, when they come in the decompensated state, you can actually off most of the medication. If you ask me, I can off the aspirin because the patient might need to go for surgery, so you need to stop it at least 5 to 7 days. Okay, and the amlodipine and perindopril, don't be too afraid to stop it. Don't be too afraid to look at the numbers. The BP is slightly on the high side, 140, 90. What should I do? Can I stop it? Yes, most of the time you just need to monitor. Okay, you'll be surprised. I remember in the past, I was called by a junior doctor. I was a peripheral medical MO at that time. And he asked me, this patient come in with necrotizing fasciitis, septic shock. Patient is on amlodipine. Can I stop it? I said, huh? Patient is on inotrol. Why don't you just off it? You don't need my permission. Because these are rare circumstances where they are very doubtful. So you'll be surprised. Sometimes these kind of things you might miss out as well, even in the emergency department. Okay? And the atorvastatin, calcium carbonate, all these supplements are not very useful in this state. And furthermore, most of these kind of patients, they have difficulty swallowing. They have poor appetite when they're hospitalized because of their different environment. Okay, and metformin, perindopril, and empagliflozin can be withheld during in AKI patient and acute illness. Okay? And then, of course, we look at the hydration status and correct volume status. Unfortunately, there's no magic pill or magic number here. There's no easy way to do this. Okay, it should be, but the principle is you should be goal-directed. Okay, use whatever available tools that you have. After you give fluid, you have to assess the patient. In ICU setting, you have a lot of indices to look at. You can do stroke volume variation, pulse pressure variation, look at your arterial pressure, a lot of things. Okay, but if you don't have that, it doesn't mean you cannot do it. Okay, you still can look at their blood pressure, look at their pulse rate, and you look at their urine output. Okay, and of course we have to avoid too excessive fluid or too restrictive. There's a lot of studies looking at this. Okay, one of it is a relief trial, which shows higher risk of AKI in fluid restrictive protocols, and of course higher mortality and morbidity in those patients who is given too much fluid. And what choice of fluid should be given? This one has been debated for many years. But as long as you have whatever available to you, which is a balanced crystalloid, we can use darafundin. You can use plasma light if you're rich. If your hospital is rich, you can use plasma light. And try to avoid colloids or albumin. Only in certain indication where you use colloids and albumin. I am not very comfortable with giving all this, except in if I have a place where I can monitor the patient very well in ICU. Okay, so the cornerstone of fluid therapy is just monitoring. There's nothing to replace monitoring. After you give fluid, you have to monitor. Okay, look at hemodynamic urine output, correct any electrolyte imbalances. Okay, as we know, AKI, it's not just about fluid, but also your electrolyte and acid-base disorder. And of course, you can monitor the renal function daily. Okay, so when do you want to do dialysis? So this is one of the important question that people used to refer nephro. So the classical indication everyone knows, refractory severe hyperkalemia, not responding to medical therapy. Recently, I was referred from not too long ago, not recently. Okay, when I was in Selayang, I was referring a patient with a hyperkalemia, and the doctor actually told me has given 7 times triple regime. I said, huh? Why you don't want to give 7 times? You can refer me earlier. It doesn't matter, you know. And yeah, it's don't wait for it to be too severe, okay? Or any fluid overload with pulmonary edema, especially when they don't have a lot of urine despite on diuretics. Any complication of uremia. Okay, in the past they say uremia itself, but uremia is a very vague term, you know. A lot of people say, oh, uremia 27, uremia already, this one need dialysis. 30, okay, this is my threshold to dialyze. So there's no cutoff value in terms of the urea. Okay, but if you have complication which is associated with uremia, like uremic pericarditis, encephalopathy, neuropathy, or myopathy, yes, they need to be dialyzed, okay, or any severe refractory metabolic or sometimes in respiratory acidosis also, because it helps with ventilated patient. And of course, certain drugs, okay, that you need to dialyze them. And aside from that, we don't just look at the indication for kidney replacement therapy. Of course, we look at the trajectory of the patient. If we think the patient he's not doing well, because every numbers has a story behind it. We look at the patient and we need to assess accordingly. And of course, at the back of our mind, every time someone refer to us for dialysis support, we also need to think about the potential risk of kidney replacement therapy. Am I doing more harm than good? Am I doing more benefit than harm? So of course, we look at this thing like it's not like a priority for us, you know, sometimes. And then of course, other factors, whether we have enough machine, enough staff to do it. If the patient refuse or if the family refuse, what am I going to do about it? And then of course, there's whether we think this patient is at the end of their life already, the futility of treatment itself. So we look at the prognosis as well, not just dialysis based on numbers. Okay, so what kind of kidney replacement therapy that is available to us? And we can see here there's a continuous kidney replacement therapy. Classically, we prescribe in most centers. If a ICU is a closed system, it will be prescribed by the intensivist themselves. CVVH, CVVHDF, a lot of modalities, okay? And then intermittent hemodialysis. This is what we usually do, okay? And then we also have our hybrid, which is like your SLAD, okay? Slow, low efficiency dialysis, and you can modify the therapy accordingly. Can be performed over 6 to 12 hours depending on your staff and resources. And then don't forget peritoneal dialysis as well. Can be used. Many years ago, we used to do stat PD in patients who don't have any vascular access. Okay, so you can do this and put them on cycler machine. So what are the advantage and disadvantage? I don't want to elaborate too much on this. I think intermittent hemodialysis, it's a lower cost, less bleeding, less interruption, better for hyperkalemia because it's very fast. Your blood flow is faster than your continuous renal replacement therapy because it comes with disadvantage. It's not suitable in patients with raised intracranial pressure. or not suitable in patient with very unstable hemodynamically. And sometimes you dialyze once and then you think, hey, you need to extract a little bit more. So sometimes, yeah, you only do it over 3 to 4 hours, and then you have to do it again. It's a bit difficult. Okay. And this is a bit controversial, but the dialyzer that we use for intermittent hemodialysis does not remove cytokines as opposed to your CRRT. Okay. So whatever disadvantage here in your intermittent HD can be your advantage for your CRRT. It has better hemodynamic control, easy fluid balance control, and has continuous removal of toxin. Cost disadvantage, greater cost. And there's a risk of hypothermia because these are extracorporeal therapy, meaning your blood is outside of your body, so there are risks of hypothermia. And you need to expose them to anticoagulation. And nowadays we use RCA, which is what we call as regional citrate. And of course, we have to monitor them. There's a lot of complication if we don't monitor them accordingly. Okay. And then when you put patient on continuous renal replacement therapy, they will be immobilized for very long, 24, 72 hours. So before you put patient on CRT, you have to make sure the patient is not planned for any immediate procedures like CT scan or surgery. So when do you want to do dialysis? When is the best time? So I don't have a very good answer in this. Sometimes our colleague says, you have to dialyze early. And then we say, we dialyze when it's indicated. Not necessarily anyone is wrong here, but it's true. All this while, we have a lot of studies. And back in 2016, there's these two landmark studies, which is called as ELAINE and AKIKI, with a contrasting result here. And if you look at ELAINE, it's a single center study that is predominantly surgical patient. And they show there's a differences in mortality. We dialyze early, 39 versus 54%. But and of course, the patient who are dialyzed earlier, they have shorter kidney replacement therapy duration and shorter stay in the hospital. But if you look back into the paper, the early versus late, it's only a difference between 4 hours. The early KRT criteria is within 8 hours, and those who are delayed is within 12 hours. Not too much of a difference. So there's a lot of variables which confounds to the study. So after that, they try to prove when is the best timing. All this while, we have AKIKI, Ideal ICU, Start AKIKI, Start AKI, and AKIKI 2. AKIKI 2 is a bit controversial because they delayed the kidney replacement therapy longer than usual, even the patient needing dialysis already, even with a traditional indication. And they found they don't really have an answer for that. There's no difference in mortality, whether you dialyze early or late. But if you dialyze too late, as in AKIKI 2, patient, of course, they die faster. Okay, so with that, I just want to give you my take-home message. AKI is a clinical syndrome. It's not a diagnosis. And recognizing early risk can reduce incidence of AKI. And there's no universal single parameters to trigger dialysis. And I would like to quote strength flows where unity grows. Peri-operative management of AKI requires multidisciplinary effort. Okay, so the communication can improve not just among the doctors, but also to the staff that is managing the patient. Thank you so much.
Thank you, Dr. Jason. Very, very nice lecture. I think I learned a lot. So without further ado, we shall go into the question and answers. We have a bit of a number of questions to our moderators. We'll start with the first one. I approach to a question to Mr. Fairuz. Is there any recommendation of minimum duration in surgery that warrant a bladder catheterization? For example, a hand surgery of 3 to 4 hours.
Okay. Thank you for the question. So, the question is whether there's any recommendation in terms of duration of surgery. So if the surgery involves an area where it's far from the genitourinary tract and perineum, then I would say that depends on the patient body weight and the duration. So body weight is because 1 kilogram of body weight produces roughly 1 ml per hour of urine. So first of all, you need to empty the bladder prior to any surgery. You can ask the patient to pass urine prior to any surgery so that the abdomen remains empty. And roughly anything below than 3 hours, and when there's no usage of diuresis during that surgery, usually try not to catheterize a patient. But if at all you are worried, you can always insert a catheter, but you should just remove it at the end of the surgery once the patient is out of anesthesia. Because sometimes you thought the surgery would be around 2 hours or 3 hours, but then after that turned out to be longer than that. So it's not actually a black and white area sort of things, but there are certain things that you can consider, such as the estimated urine output during that surgery and whether you anticipate any difficulty and prolonging of surgery. But if at all you're worried, you're not sure, I'm not saying that you should not insert a catheter, but at the end of the surgery, when there's no actual indication for it to stay longer, just take it out. Yep.
Yes. Very good. I agree as well, Mr. Firoz. To our next question, directed to Dr. Jason. In a CKD patient with hyperuremia, what is the cutoff value safe to proceed with general anesthesia to minimize the risk of delayed emergence of or delirium?
Thank you for the question. I'm glad someone actually asked this question. What is the cutoff value? I mentioned in my presentation, there's no universal agreement on what is the cutoff value which is safe. So if you ask me, it's very individualized. Okay, when we look at the patient, we don't just look at the urea. We ask, the first thing is, how urgent does the patient need the surgery? Is the condition life-threatening or not? If it's very emergent need for surgery, yes, we can support dialysis provided the patient has even if the indication is borderline, we don't just look at the urea. If the patient has a bit of metabolic acidosis with reducing urine output, the urea slightly on the higher side, and the patient really need the surgery, okay, and of course a good communication between your teammates and your colleagues, and depending on the surgeon preference as well and their comfort level, and of course the anesthetist that is handling the case, because at the end of the day it's a teamwork. It's not just me doing the monitoring, doing the management, okay? Because we know the monitoring will be done most of the time is in ICU. So I don't have a cutoff value, okay? But in some centers for elective surgery, they say less than 25. And then even some procedures, they want less than 20, but yeah, it's very individualized. I cannot give you a number there. I cannot quote you a number. A lot of studies has been done to say which value is a safe value. There's no evidence to say which is the safe value, because urea can be raised in a lot of conditions. Some medication can cause it. And in some condition like your upper GI bleed, it can cause very disproportionate urea and creatinine level. So yeah, it's very individualized. So back to what the patient has and what is your priority, not just the AKI. So yeah, for me, I will try to discuss with the managing team as well. So, and I see the second question here, also a very good question. I think something about healthy athlete plan for surgery. Is it?
So the next question is in regards to in a healthy athlete plan for surgery with an isolated eGFR of 53 and a creatinine of 135, asymptomatic with a good urine output, how to investigate as surgeon would refuse to delay?
Okay, so the answer goes back to my first question as well. So if the surgeon refuses to delay, means the priority is there. So there must be a need for the surgery. Okay, the investigation, yeah, you can refer to nephro. Okay, for a healthy athlete with a eGFR of 53, a creatinine of 135 definitely might not be a normal reading. So first of all, we need to see whether there's any baseline creatinine, whether this is something acute or is it really a CKD? If it's CKD, whether it's stable CKD or not, whether it has been worked up in the past. And of course, as we know, creatinine can be raised in different body habitus and their diet. So sometimes the athlete, they take some supplements which can cause them to have raised creatinine, but this is not normal. So what we usually do is we rule out one of my slides I mentioned about the pre-renal and renal and post-renal causes. So that's what we can do, rule out obstruction, rule out any pre-existing medical condition that predispose the patient to CKD, like diabetes, hypertension, any proteinuria in the past. If still unsure, we can send off some autoimmune screen or everything. If all the workup is negative, we can even do renal biopsy. Of course, if the surgeon refuses to delay, the renal biopsy is not a priority. Okay, we can do it later.
Okay, thank you, Dr. Jason. Another question to Mr. Fairoz. What is your advice on managing catheterization on a patient known to have BPH, catheter selection, and safe removal?
Okay, so in patients with BPH, I'm assuming that this is patients who can no longer void on his own, so it's a catheter-dependent BPH. Then it's usually difficult to ask the patient to do clean intermittent self-catheterization because the prostate would be big and vascular. If you do CISC, then you would cause unnecessary bleeding. Usually. So you can have an indwelling catheter, usually change every 2 weekly, but I would advise that you advise the patient to use a catheter tap valve so that he can empty the bladder every 3 to 4 hourly, so to maintain the function of the bladder while waiting for surgery. But mind you, once a patient with BPH is catheter dependent, it is actually a strong indication for the patient to undergo either TURP or any corrective surgery to take out the prostate so that the patient can be taken off the catheter. Yep. That would be my advice.
Another question to Mr. Fairoz. I would like to ask if bladder training clamping CBD 4 hourly prior to any CBD removal is still applicable in current times.
Yes, we used to practice this, especially in patients who have been catheterized for let's say 1 or 2 weeks, but there's no evidence to support this. The 4 hourly practice, the bladder usually does not forget in terms of function if he has just been catheterized for 1 or 2 weeks. Okay, usually it's quite safe to take out the catheter after a relatively short period of catheterization of 1 to 2 weeks without the 4 hourly clamping. But having said that, it's not wrong if you want to practice it, but there's just no evidence to support it. That's all.
Thank you, Mr. Fairoz. Another question directed to Dr. Jason. Do we still say acute on CKD, and what category it falls into, AKI, AKD, or CKD?
Thanks for the question. Yeah, so patient with CKD that is not dialysis dependent, and when they develop AKI, of course they have higher risk. Actually, this is one of the highest risks to develop AKI. So we call them as a AKI with a background of CKD. So AKD is when you're not sure, okay, you don't have a baseline creatinine. Maybe the patient just admitted a month ago, creatinine was 130. That time was asked to investigate in the nearest clinic. But before he goes to the nearest clinic, the patient come in again with a similar problem, so you're not sure whether this is AKI or AKD. So sometimes AKD is just a term to confuse us to further lah, okay? Basically, if it's not AKI or CKD, it's in between, you're not sure it's AKD, okay? But CKD, as long as you know what is CKD, you can roughly know what is AKI already, okay? So if a patient with background CKD, you can just say this patient has AKI with a background of CKD.
Okay. A patient with a CKD or AKI with borderline numbers, for example, urea is high or mild metabolic acidosis, no clear-cut acute indications for any HD. Is there any evidence on pre-op versus post-op HD on patient's outcome?
Very good question. Yeah, I think again, there's not much evidence to support what are the numbers to say the patient has better outcome post-surgery. Okay, of course, ideally we want a normal patient without any comorbidities, no electrolyte or acid-base disorder or imbalances. But sometimes we have to weigh the benefit and harm by doing an additional procedure. And sometimes this procedure can delay the surgery itself. As you know, dialysis is not something that you order, and then it can immediately be done. You have to mobilize the staff, you have to insert the catheter. So that will take roughly a half a day already, if you ask me, even if you order an urgent dialysis. Because when you order an urgent dialysis, it's not just one patient, there are a few patients waiting. So depending on the availability, your dialysis can be, postponed slightly longer, can be delayed. So we have to take into account whether the patient doesn't have any urgent indication for dialysis. If I can correct these numbers with medical treatment, we try our best. But in terms whether the outcome has better outcome, urea is high, will have worse outcome, there's no evidence to that. Okay.
Thank you, Dr. Jason. One more question. Why is STEP PD no longer practiced in AKI patients presenting critically, especially when we have limited HD capabilities?
Thanks, Mr. Virus, for the question. Yeah, STEP PD, of course, our policy is actually moving towards PD first policy, okay? But these are elective for patient who requires long-term kidney replacement therapy. But in emergency setting, number one is because it's more staff intensive, you need the staff to come to help them to do the exchange, okay? And we don't have a lot of staff helping us doing it, but we have on-call hemodialysis staff. In the past, we used to train the HD staff do the peritoneal dialysis exchange in the critically ill setting. But as we know, we order more HD, so they don't have a lot of time to do PD. So it's actually more to staff and your resources. And of course, another thing is PD catheter insertion has become a bit more safe nowadays, we will say, because you're doing Seldinger method rather than just step PD with the Bramula. So we ideally we are practicing safer medicine here. So we've seen a lot of complication associated with PD catheter. Not to say inserting a femoral or IJC is safer, but of course it depends on your center whether they are willing doctors to learn on how to insert the PD catheter. Yeah, so that's another thing that we take into account, mostly about limiting the limited resources. That's why we stopped doing PD. And then there will be question when to remove the catheter. So it's a bit difficult. If a person who is capable enough to do the step PD, and then he's on leave, and then another person who comes along, and we tell, oh, this patient doesn't need the exchange anymore, can you remove the catheter? And the person might not be able or not comfortable to do it. So yeah, so So in a way, it's just our mindset has shifted towards HD in critically ill patient, and PD has moved on to more to patient needing chronic dialysis.
See. So just out of curiosity, we do not do any step PD anymore in Queen.
No, we do a bedside Seldinger tank of catheter insertion, not
Oh.
step PD.
The last time we ever did a step PD in Queen was 10 years ago.
Yeah, very long ago. Yeah,
Yeah, because
yeah.
because I just remember when I was doing housemanship, I used to do step PD, but I think in current times we no longer perform this in view of our current modern treatment options that we have rather than doing step PD because
Yeah.
it's scary if you perforate the bowel though.
Yeah, then it will be a mess already, Miss Jane. We will have to refer to you already.
Okay. Thank you, Dr. Jason. Very nice topic over there. Okay, so if there's no more questions, I would like to conclude our webinar today. Please don't forget, you can register in our society. It's very useful for throughout lifelong learning. And we have a third of our webinar series, which will be on the 8th of November, also between 10 a.m. to 12 p.m. through Zoom. And the topic will be regarding perioperative care for older people and fragility hip fractures. So in particular, we have also invited another two more speakers, consultant geriatrician and a physiotherapist, Dr. Elizabeth and Ms. Nur Hidayu. They will be presenting on their respective topics, as well as our moderator, Dr. Nitya, who's an anesthesiologist from Hospital Selayang. So I would like to thank you everyone for joining our webinar. I hope you have learned a lot. Please do share our society info to the rest of your colleagues. Thank you everyone for joining today.
Thank you.
Thank you, Jane.
Thank you.
The registration and feedback.
Oh yeah, I forgot. You can please register. Sorry, can you please fill up this feedback form, now registration form. Thank you. Share it. Can fill in the remaining many participants can fill in the webinar CPD registration and feedback form in the chat box. Thank you.